So what I will do, I will first go over with you here on the left. I will give an introduction on why a metal implant. And in order to answer that question, what is the problem we need to solve? What other solutions are there to solve that problem? And then obviously we come to the metal implant. I will talk about the first generation metal implant and then the second generation. The second generation being the Episealer, the indication to the Episealer, contraindications, the treatment algorithm, then to the preoperative planning, the damage assessment, which is particularly interesting. We will talk about it. And then the surgical technique we will go over in small little videos. And of course, we will end with questions, and you can put your questions already during the presentation. And Daniela probably already has explained to you how you can do that. So why a metal implant? What is the problem that we want to solve, and what is the purpose of our treatment? And basically this is the patient, a typical patient with deep ankle pain on walking, and on investigation, there's nothing specific to find, maybe little synovitis, but on the x-ray, we might see an osteochondral defect, localized osteochondral defect. In most cases, we do not see changes on the standard x-ray, and we have to make an MRI, and then we will see the bone marrow edema if there's an active lesion, and then we can make a CT scan in order to exactly see the size of the lesion, the location of the lesion, if there's a cystic lesion, how large it is, and this is then an anatomic specimen. This is the lesion that we talk about. So if we have such a patient with an active lesion, deep ankle pain, then what is the purpose of our treatment? And the purpose is twofold. First is to resolve the symptoms of the patient. And the second is that we might want to prevent deterioration of this ankle, and that without our treatment, it will go to osteoarthritis later on. And in fact, this last issue, the prevention of osteoarthritis, in the vast majority of cases, it will not develop to osteoarthritis, but the larger lesions, the lesions of 15 millimeter and more, obviously they are prone to osteoarthritis. So these are the ones that we might want to treat in spite of the fact that they are low symptomatic. So what is the symptoms? The main symptom is pain. These patients have deep ankle pain on walking. And if we then look at this schematic drawing of the ankle joint. The ankle joint is the most congruent joint in the body. The joint surfaces fit exactly onto each other. And this is a schematic drawing of a knee joint. The knee joint is the least congruent joint in the human body. And these joints that are not congruent, they have thicker cartilage. So the knee has 2.2 millimeter thickness of the cartilage, where the ankle, which is the most congruent, has much thinner cartilage. And on walking, the cartilage compresses. And on cyclic loading, it's about 10%. And in the knee joint, it is 60% because there's more compression. And on static loading, it is almost half of the cartilage that is compressed in a knee joint and about 38% in the ankle joint. So basically, if we measure our length in the end of the day, if we stand all day, we are shorter in the end of the day than when we rise in the morning because of this compression of the cartilage in basically the ankle, the knee, and the hip. So on loading, 75% of the cartilage is water. So the water is compressed and goes into the joint, and on unloading, the water goes back into the joint. That is, it's like a sponge on walking in an incongruent joint. In a congruent joint, it's the same, the compression of the cartilage, but in this case, the water cannot go into the joint space because of the congruency, and that is the reason why the cartilage is not so much compressed. So what happens in a pathologic situation? In a pathologic situation, if there is a defect in the subchondral bone, on every step of walking, the water content of the cartilage is compressed into the bone. It cannot go into the joint space because of the congruency. So the only way it can go is going into the bone, leading to bone marrow edema on T2, as you see here, and in the end to cystic lesions. Cystic lesions you only see in congruent joints. You see it in the ankle, you see it in the hip, which is also a congruent joint, ball and socket. But you don't see it, or to a much, much lesser extent, in incongruent joints, because the water doesn't go into the bone, it goes into the joint space. And there's nerve endings in the bone, so this pressure is detected by the nerve endings, and that's the reason for this deep ankle pain in these patients. And when we look at the treatments that we have, and this is from a publication that we did in 2000, and this was in 2010. We looked at all the treatments that we have for localized defects. And the interesting thing is that the 4 treatments that have the highest percentage of good and excellent results is the treatments that not just treat the cartilage, but also the bone. Bone marrow stimulation, oats, obviously is bone and cartilage. Retrograde drilling, it's the bone that we drill for large cystic lesions, and fixations for also large lesions. We fix the cartilage and the subchondral bone. So treatment of the bone is important. And in order to understand the mechanism of the metal implant, I will show you this interesting patient. And it is a patient with a defect. This is the preoperative CT scan. This is maybe a 1 centimeter lesion. It's the average lesion that you see in a patient with a localized osteochondral defect. I operated the patient, and 2 weeks post-operative, we made a standard CT scan. We did not do it because of complaints, but it was because of a scientific research project. And you see, probably the cartilage lesion was larger, so I made a much larger lesion, a lesion of 1.5 centimeters. So now it's a critical lesion. So what happened is that the compression now is on the edge here of the healthy cartilage. There's no compression, or much less compression, on the original defect. Even if it's filled with fibrocartilage, the compression is on the edge. And that's exactly 1 year post-operative, where you see a new cystic lesion if you have a large lesion like this. So this principle of edge loading for large lesion is very important to understand the mechanism of persisting complaints and prevention of those complaints with a metal implant. And I will show you that schematically, because this is the patient with the 1 centimeter defect. This is the defect. So debridement bone marrow stimulation, we take it away. It will fill from the bone marrow with stem cells, fibrocartilage, a new subchondral bone will be formed. And this is maybe after a year, we have fibrocartilage, but it's a small lesion, and the patient has no complaints. This is the typical good result that you have with debridement and bone marrow stimulation. However, if the defect is larger, now we have the same filling with fibrocartilage, but then the compression is on the edge, and you see the compression, the tilting of the talus, you see, because of the compression, it tilts, and now we see the cystic lesion appear here where is the highest compression. There's also more compression here, more compression there. And if we continue with this patient, then you see maybe more cystic lesions. And in the end, you might see a cystic lesion here on the medial malleolus. You all have seen those patients with these larger lesions. Finally, the cartilage dissolves, and then this is this type of patient that you all recognize from your practices. So how can we prevent this edge loading in a large defect? Prevent the loading of the edge. If we put in a metal implant and we put it in under recess, like you see here, then you see what happens on walking. Now the implant protects the edges of the cartilage, and that is what happens, and that is the working mechanism of a metal implant. So this is my treatment algorithm. Low symptomatic lesions, conservative. The symptomatic lesions, smaller than 15 millimeter, excision curettage bone marrow stimulation. Larger lesions, you can fix it. And oat metal implant are the alternatives. Retrograde drilling for large cystic lesions. And then for secondary lesions, oat cartilage implants, and osteotomy. Always think about osteotomy. Alignment is a basic orthopedic principle, very important. And again, the metal implant. So the first generation metal implant, we published last year the results of the first 50 plus implants of the hemicap. Here you see it. And the survival rate was 94%. The follow-up was 2 to 10 years. So it was a quite good result, because all these patients were secondary lesions. They had primary surgery before, sometimes secondary surgery. And so we were very happy basically with this result. 80% indicated they would undergo the surgery again. 88% recommended the surgery. Here you see the mean time of return to sports, 4 months. 90% work resumption, but 21 reoperations in those 50 plus patients. Medial screw removal, anterior impingement, realignment to salvage this prosthesis. What was interesting was the second look that we did in 6 patients. And you see what happens if the implant is below the surface fills with cartilage. So this is fibrocartilage that was grown from the edges over the defect. Here again, this is the cartilage which is over the implant. This is a patient in which the implant was a little bit too proud, because you see this is the cartilage of the talus, and here is the implant. Now it's not covered because it was too proud. And if it's too proud, then you see there is some fraying of the cartilage on the opposite surface. So this was a failure because the prosthesis was too proud. This was a good result because the prosthesis was below the surface. So it shows the importance of the correct placement of the prosthesis. So then to the second generation, and what the issues were with the hemicap was first the osteotomy, because in order to implant it correctly, the osteotomy must be at the correct level. This is the correct level. But if you make it a little bit more here, it is very difficult to get it in because of all the instruments you have to, guiding instruments you have to place. So the exact location of the osteotomy is a problem, not a problem, but is an issue. Size of the implant, there were only 12 implant sizes, and you see it doesn't fit exactly because you have to choose during the surgery what is approximately the best implant for the talar defect that you created. It was very difficult to measure exactly how to place the implant, because once you have removed the defect, then you have a hole, and then it's not, your reference points have gone. So it's not so easy then to place exactly the central K-wire because there's no cartilage surrounding it anymore, because you removed it because of the lesion. So the guiding instruments were not very accurate. Size of the screw, I was always afraid that I would go into the subtalar joint. It's very bulky because it's the same screw as for the knee. It's a one-size-fits-all screw, and it's a little bit big for the ankle. And there was only an implant available for the medial side, not for the lateral side. And of course, we have also defects on the lateral side. So with this Episealer, we now can do the osteotomy correctly because we have this very nice guiding instrument which is specific for the patient. It's made based on the CT scan of the patient, so it fits to the patient, and you can have your slot and have the right depth and the right location. The size of the implant, it is made to fit for the patient, so it is exactly fitting. The instrument to place the cap, the Episealer, during the operation, it is again like the guide. It is made for the patient, so there's no issue in the precise placement of the prosthesis. And there's no, it's only a small stem, so not a big screw. So also when you have to convert to an arthrodesis or prosthesis later, you don't lose a lot of bone, and there is an implant available for the lateral side. So the indication for the Episealer is patient with a focal osteochondral defect of the talus, which does not respond to conservative treatment. And obviously we have contraindications, and you can read it through, but the most important is that it should be a localized defect and not an arthritic joint. Instability or malalignment of the ankle joint is a relative contraindication. And of course, you can read through the other indications or contraindications like you would expect for an implant like this. The alternatives, we talked about it, excision curettage bone marrow stimulation, oats, retrograde drilling for large cystic lesions. These are the alternatives. So then to the damage assessment, and basically it is done, you make a MRI or a CT scan, and then based on the MRI or the CT scan, the defect is localized and the guides are created. And here you see, for example, the CT scan. Here you see the guide for the, here from above, the guide which fits onto the anatomy of the patient. And this is then the osteotomy. But if you feel more comfortable having the osteotomy like here, then you just have it here, because then it will be adjusted and you will have the osteotomy guide here. It's up to your preference. This is ideal because it's not in the weight-bearing surface, but you can adjust it to your own preference. And here you see the guide for the cap, for the Episealer, which again fits exactly to the patient, and this is then the implant. The toolkit, we talked about it already, the guide for the osteotomy. It will give you also the depth, exact depth. And this is the toolkit, which is relatively simple. Here you see the guide, here you see the Episealer, and this is the instrument, which is basically very, very simple. This is the damage assessment. So the MRI CT is made. Here you see the CT scan. CT scan and or MRI, you can go through it, and here you see the defect. The defect is marked onto the surface, and then based on this defect, the best sized Episealer is constructed like this, and basically that is how it is done, and based on that, the osteotomy guide is created. So then to the operative technique. The incision is straightforward over the medial malleolus. Here you see the back of the medial malleolus, the front of the medial malleolus, and this is the incision. Then we will develop the anterior working area. You see there is the ankle joint in front, so you can access the talus. Then we will place a Hohmann retractor in front, initially like this. And then what I like to do is to have a small Hohmann retractor, which I will drive into the bone, and I will show it. Here, this is the initial Hohmann retractor. Now I take a small retractor here in front. You see, I place it there, and then I hammer it into the bone in front of the, like this. So now I don't need my assistant to hold it, and it gives me the nice exposure in the front. Then here I go in between the posterior tibial tendon and the medial malleolus. So I protect the neurovascular bundle posterior and place a Hohmann retractor. Then the osteotomy. For the osteotomy, we make we place the guide, the guide that is made to fit the patient. Here you see it, and you see it fits. There's only one possibility to fit it on the anatomy of the patient. Here you see it. Once we are happy, then we will secure it with 2 K-wires, and this is to drill the screw, the 2 screws that we will put at the end of the procedure to fix the medial malleolus osteotomy. Then the saw through the slot, like this, and it will end 1 millimeter from the cartilage. So you cannot go through the cartilage. So you need an osteotome for this last 1 millimeter. You can use a small osteotome. I usually prefer to start directly with a large osteotome, but you can start with the small diameter osteotome like I show you here, and then to finish it with the large one in order to angulate it like this. And you see, this is a nice movement. Now you dislocate the, with my thumb, I dislocate the medial malleolus away from the osteotomy, like I was showing you. Here it is dislocated away, and this K-wire holds it in the dislocated position. Why do I place this K-wire? Here I place a second K-wire in order to place the distractor, the Hintermann distractor. So this K-wire is there to displace the medial malleolus, and it is extra-articular. It is through the deltoid ligament, in fact, into the talus. This is more proximal. This is then the the Hintermann distractor. And then you see how nicely opens the ankle. And this is what you use, this additional space you use to place your the guide. And you see the guide, there's only one possibility how the guide fits. So you fit it onto the talus until you're happy. You press it on. There's only one possibility to place it, and you secure it with the K-wires, like is shown. Then the drilling. The drilling, you see this centralizer. The centralizer is just to make a central hole. Quite simple, a simple hole in order to place the drill, because this is the drill. So this goes in the centralized hole. This is for initial drilling. Now we go with this instrument, and it goes to 0 millimeter up to this point in the guide, and we drill to 0 millimeter. So basically, with this drilling, the cap, the trial cap, should be exactly at the level of the cartilage. We clean it, and then we will check if we are at the level of the cartilage, which is basically too high, because we want to have it recessed a little bit below. But initially we start with placing it exactly at 0 level, which is at the level the cartilage. So we check, this is the trial cap, and now we check if we indeed are on the level of the cartilage surrounding it. We check that that's indeed the case, so we want to place it 0.6 millimeter below that level. So this is 0, this is 0.2, 0.4, 0.6 below the level. So if we place it here, it will be flush. Now it's minus 0.2, minus 0.4, etc. So we place it 0.6. We place the 0.6 to this this part of the guide, and we drill. And after the drilling, we check it again to see if we're happy. In this case, I wasn't happy enough. I wanted to go to 0.8. So I placed it again and went to 0.8. There is 0.8. So put it in again. I drilled it again, and now it was 0.8. Then you mark on the cartilage opposite this arrow, you mark it on the cartilage, because the marking is important later on to place exactly your implant. So then the implantation, first clean it, make sure that the edges of the cartilage like this are nicely clean. So I clean it. This is the implant, and there is a mark on the implant which has to face, and there is the mark. This is the mark, a little indentation, and it will go opposite this marking that I made with the pen before. And then you have this driver to first with my hand, and then I manually put it in, I hammer it in, and then I check if it's flush. Not flush, it should be a little bit under recessed. You see, it's a little bit under recessed, so that's perfect because of the compression of the cartilage. And then in the end, we fix the medium malleolus, the two guide pins in the holes that we prepared before. And then initial compression I give with this clamp, this Weber clamp, initial compression. And then we exchange the K-wires for the 3.5 compression screws. And then we remove the positioning clamp. And then we have the end result with the two screws nicely secured like this. So that's the procedure. So now we have started with a multi-center trial, cohort study level 3 on the first 25 patients, but the Episealer has a CE mark, so it's possible to use it. And if you use it, it would be great if you could fill in forms, because the feedback is important with a new implant. It is important to know the fate of these implants. But in summary, this is basically how it works. For me, if you have a defect, it doesn't matter so much what is the filling. If it's metal, of course, it would be nice if it could be hyaline cartilage, but in this big defects, that is really difficult. So this Episealer, I believe, is a very good alternative.